complex non-vascular interventions for the next half an hour or so. During this talk, we'll cover three topics in non-vascular interventions, which are very commonly encountered in interventional radiology. That's biliary interventions, GU, and percutaneous sepsis drainage. So we'll start out with biliary interventions. That's probably the most complex topic as far as content. Biliary anatomy review, drainage, and cholecystostomies. So a very quick review, first of all, of the Quinault segmental biliary anatomy. As you know, liver is divided into 8 segments. Segment 1 is the caudate lobe, and then you have 2, 3, and 4 in the left, and 5, 6, 7, 8 in the right lobe. And the drainage of these ducts, as far as the biliary anatomy is concerned, follows the segmental anatomy. And what you have is the common bile duct, and then you have the right main duct and the left main duct that ultimately give segment 2, segment 3, and segment 4 segmental ducts. And then the right duct divides into the anterior and posterior divisions that ultimately give segments 5, 6, 7, and 8. One thing to consider when you're looking at the anatomy of the biliary tree is that there can be quite a bit of variability in the insertion point of the right posterior segmental ducts. That's the one that drains segments 6 and 7. This duct, in this particular image, is draining into the left hepatic duct. But where it can drain is pretty much anywhere along the right hepatic duct. It can create a trifurcation here, so there's essentially no right main duct. You'd have anterior and posterior ducts coming out right here. It can certainly insert here on the left, as you can see in this image. And this is a particularly treacherous anatomic situation, because here the right posterior segmental duct is inserting on the common hepatic duct, not very far from the cystic duct. And so in the setting of laparoscopic cholecystectomy, a surgeon might actually mistake the cystic duct for this posterior division right hepatic duct and can transect it and cause a biliary leak. And so this is a very important anatomic variant to recognize and identify. As far as biliary imaging is concerned, you have any number of different modalities. Very commonly we use non-invasive modalities first, such as CT and MR cholangiography, and then you have invasive options, either endoscopic or percutaneous. Oftentimes the question arises which one to pursue first, and usually there is clear indication or contraindication that will help guide your decision. Most of the time nowadays patients would have an endoscopic approach first, because that is much less invasive, much less traumatic, and a simpler recovery compared to percutaneous approach. However, if a patient, for instance, has a surgical biliary anastomosis or unfavorable GI anatomy or strictures where an endoscopist might not be able to pass a scope, then a percutaneous approach is going to be utilized first. Sometimes you have to employ both modalities. For instance, in this example here, where ERCP is being performed, and you can see that there is very nice filling of the left-sided bile duct segments 2, 3, and 4 ducts. And then I'll tell you that this patient has not had a hepatectomy, so they have a right liver lobe. But notice here, and this is a very important observation to make, is that there is a paucity of opacified ducts in the right liver lobe. And this is not because of lack of pore injection. There's plenty of distal duct radicals that are being filled on the left and none on the right. So you might be concerned that there is going to be a missing right duct. And so this was actually a patient who has had a lap cholecystectomy, and there was an injury to the right hepatic duct, and the patient had to have a PTC. And here you have it. PTC is revealing that missing right hepatic duct, which happened to have been obstructed here. As you see, it's dilated. So how is PTC performed? Fine needle cholangiography is the typical approach nowadays. The 22 gauge needle is adequate under fluoroscopic guidance, plus or minus ultrasound, depending on operator preference. Generally speaking, I use ultrasound for left-sided approach, or on the right side when there is biliary ductal dilatation. If there is no biliary ductal dilatation, for instance, for cases with biliary leaks, I use fluoro only. And you start making passes that are parallel to the 11th rib, withdraw the needle and inject iodinated contrast, and hopefully one of those lackey passes will opacify a bile duct, and you'll be able to get your cholangiogram. What you're looking for findings-wise are two different categories of findings. One is a category of obstruction, where you might see dilated ducts, delayed egress of contrast from the ducts, a cutoff point at some point, and filling defects such as stone. So here you see there's complete obstruction at the confluence of the right and left main hepatic ducts. You see some clips here, perhaps a surgical complication. You don't see any contrast going beyond this point. This is a complete obstruction of the high common hepatic duct. Alternatively, you might be dealing with a leak. That's also fairly straightforward diagnosis. Basically, you see contrast leaking out of a defect in the duct. This is, by the way, another example where you see low insertion of that posterior segment 6 and 7 duct directly onto the common hepatic duct. And you see leakage of contrast here. By the way, the common duct has also been transected in this particular situation, so it's obstructed and leaking at the same time. If you're dealing with malignant obstructions and you're suspecting a malignant obstruction, based on where the obstruction is, you might actually be able to suggest a diagnosis. And so that depends on where the obstruction is. If you have an obstruction in the distal common bile duct, that might be a location of an ampullary or pancreas cancer. Cholangiocarcinomas can occur anywhere along the biliary tree or intraparenchymally, as you know, and then in the hilar region you might be dealing with an HCC metastases or gallbladder cancer. And so I'm going to show you 3 examples and try to develop a short differential list for each. These are all 3 malignant obstructions. This one in the distal common bile duct turned out to be ampullary. This one in the region of the common hepatic duct, the long stricture, was a gallbladder carcinoma. And this is a typical Klatskin tumor appearance where you have basically pinching off of multiple segmental ducts and left lobar ducts. So you see all 3 ducts are actually pinched off, and there is a stricture involving the common hepatic duct. And here this is an example of cholangiocarcinoma, but there could be mimicking lesions for this appearance. For instance, metastases, particularly from colon cancer, HCC can give this appearance as well, but this is a classic cholangiocarcinoma Klatskin appearance. As far as benign biliary strictures are concerned, there's a whole laundry list of potential causes. Probably most common causes in the 21st century are going to be postoperative, various postoperative issues, whether post-Whipple or post-cholecystectomy, but also pancreatitis and stone-related disease can be other common etiologies of benign biliary disease. Sometimes you can actually make a diagnosis on cholangiography, although most of the time you'll end up generating some form of a differential. In this particular situation, this patient had a right lobe only transplant, and the transplant was complicated by an anastomotic biliary stricture, and then the patient also developed stones, intraductal stones in the allograft proximal to the stricture. So you see these granular filling defects. These are the stones, there's the stricture, and you can pretty much cinch the diagnosis of a benign biliary stricture complicated by stones this way. This patient has very, very typical findings of sclerosing cholangitis. You wouldn't know whether it's primary or secondary to something, but what you're going to notice here is that there are numerous, the more you look, the more you see areas of smooth narrowing, alternating with smooth dilatation of multiple duct segments. And so this is a typical appearance of PSC. This patient actually has had a history of cholangiocarcinoma, and that's why the left lobe of the liver is missing in the setting of PSC, which is a risk factor. And then this was a young patient who had recurrent pyogenic cholangitis. You see the ducts are extraordinarily bizarre. They're incredibly irregular. They're very dilated. There's areas of narrowing as well. There is a huge amount of debris in these ducts, and so this is a typical appearance of recurrent pyogenic cholangitis. Some of the diagnosis you can make. Now, if you decided that a patient requires biliary drainage, you might want to put in a drain. The indications for drainage are going to be palliation of symptoms. For instance, for a patient with malignant biliary obstruction who presents with jaundice or pruritus, might be indication for putting in a drain. Alternatively, there could be a stricture or a leak requiring a biliary diversion, so that might be an indication, as well as access for stone retrieval. So those are the typically three things that are mentioned in this scenario. There is not a whole lot in the way of contraindications. Sometimes there's anatomic issues. For instance, in this case, colitis, there's a colon anterior to the liver, and you simply don't have a safe window. If there is ascites, some practitioners would consider that a relative contraindication. A lot of the time it would be possible to perform a high volume paracentesis, bring the liver surface up to the abdominal wall surface, and perform a safe percutaneous biliary drainage. Coagulopathy and thrombocytopenia for any kind of interventional procedure also come into play, but those are typically correctable. So as far as the technique, just very brief review, we perform a PTC first, usually again fine needle cholangiography, 21 or 22 gauge, and then upon ossification of the ducts, we find as peripheral a duct as possible. So an ideal place to insert the drain would be somewhere here, away from the major vascular structures in the liver hilum. So you can use actually a second needle technique for that. First needle you just use to pacify the ducts, and the second needle to actually hit the duct where you want to place the drain. Place the wire within the duct, and then dilate the tract up and place your tube. As far as the tube sizes, I pretty much have a very simple rule of thumb that you can follow. If the ducts are non-dilated or minimally dilated, I place an 8 French tube. If the ducts are dilated, a priori, I'd place a 10 French tube. I don't usually use tubes larger than 10 French, even for massively dilated ducts in the de novo setting. But if your patient is having issues down the line with appropriate drainage and drain clogging, then you can consider upsizing the drain, 12, 14, 16 French. Some practitioners for strictures, for instance, believe in placing very large bore drains, 18, 20 French drains for a very long period of time, in hopes that the strictured segment is going to mold around that drain, and once the drain is removed, that the opening will actually stay 18 French or 20 French in diameter. Complications are fortunately rare. Vast majority of the time, if you're going to encounter something, it's going to be bleeding. Arterial issues with biliary injury, Evan showed a very nice example during his lecture. Those tend to occur in 2% or less of the biliary drainage procedures. And then especially for patients who are being drained in the setting of cholangitis, biliary sepsis can be a major issue. Pleural complications, and unfortunately there is a very small chance of death with the biliary drainage procedure. Now, what is the role of biliary stents? So we've talked about drains so far. So what is the role of stents, metallic stents? The role of metallic stents is very limited in biliary drainage. That is just really for palliation of symptoms in the setting of malignant obstruction. Why is it such a limited role? The reason is that patency, long-term patency of metallic stents in the biliary tree is on the order of 4 to 6 months. So if you're expecting your patient to live for more than 4 to 6 months, it's probably not such a good idea to give them a metal stent, unless you're planning on redraining them at that 4-month mark, or sometimes even sooner, for recurrent biliary obstruction associated with debris, or perhaps even malignant stricture that's growing over the edges of the stent. So for any kind of a benign or imminently treatable cause of biliary obstruction, stents should not be considered. So that's that example. I can go previous, went a little too fast. So these two examples basically show you two situations where you wouldn't want to put in a metal stent. This is a curable malignancy, and this is a benign stricture in the setting of chronic pancreatitis. So in those two situations, it's not worth putting in a metal stent. But what you can do is cholangioplasty, balloon dilatation, completely standard thing to do in the setting of benign strictures, and there is a myriad of different protocols. And if I asked each one of you who's performing biliary interventions which way you use, you'd probably give me a different answer. Some places advocate dilating a balloon briefly and then bringing in a patient a month later or 6 weeks later for repeat cholangiograms. Some places would perform prolonged cholangioplasties, meaning they would leave these balloons up for a period of 15 or 20 minutes and then would repeat the procedure every week and actually report very nice rates of long-term patency in the rate of 80 to 90%. In our hands, we perform these balloon cholangioplasties for a period of about 5 minutes and checking in a month, and our patency rates for all comers and benign strictures is about 50%. Meaning we're actually able to get rid of the biliary drain at the end of this whole cholangioplasty process. Then there's a whole a slew of kind of newer devices. There are these mitomycin-coated balloons that there has been some interest in terms of using for benign biliary strictures. And there is also cutting balloons, which have 4 sharp blades that are actually welded onto the balloon, and then you basically blow up the balloon. You score the strictured tissue, and then you blow it up with an even larger balloon, making larger tears, and hopefully that's interrupting the scar tissue. All right, moving on to cholecystostomies. Indications is pretty much acute cholecystitis. Calculus or acalculus doesn't really matter. There seems to be a whole lot of referrals for cholecystostomy tube placement, at least in our practice, particularly for patients who are sick in the ICU with fever. It's unknown exactly what's going on. They have sludge on ultrasound, perhaps somewhat thickened walled, and so a lot of the time they get referred for cholecystostomies. As far as technique for placement of the tubes, we recommend placing the needle. You can use ultrasound guidance, or on occasion you have to use CT if the gallbladder is not particularly distended. With a transhepatic tract. The reason you might want to use a transhepatic tract is that it prevents bile peritonitis, it prevents bile leakage from the gallbladder into the peritoneal space, and helps form a fibrous tract over time. And then you end up placing the needle, the wire, dilating the tract, and then again using a 10 or 12 French tube from the start, I think, is a reasonable idea. And then what you end up doing is that vast majority of the time you're going to achieve some form of clinical success in terms of actually relieving the symptoms of cholecystitis and improving the infection, if indeed that was the cause of the problem. One thing you have to do is you can't remove these tubes very quickly. These tubes have to stay in for at least 6 weeks prior to the fact that they can be removed. And the reason for that is that a fibrous tract has to form to the gallbladder. If you remove the tube too soon, you're going to end up with bile leakage into the tract and into the peritoneal space, and basically you can end up with bilious ascites. And so we recommend waiting 6 weeks prior to removing of the cholecystostomy tubes. Now, what might be the reason for removing the cholecystostomy tube? If there is no stones, cholecystitis goes away, and the cystic duct is patent. In those 3 situations, it might be actually reasonable to remove the cholecystostomy. Otherwise, the gallbladder should come out. All right, moving on to GU. Here we'll cover percutaneous nephrostomies and ureteral stents. So again, just like with biliary, really simple. It's just simple plumbing. It's either going to be an obstruction problem or a leak problem. With obstruction, patients might present with pain, infection, renal failure. On imaging, you're going to see hydronephrosis. You might see the etiology of the problem, like in this patient who has a obstructing stone, you might see strictures. You might even try to figure out what the cause of the stricture is, although a lot of the time you can't really say by just doing nephrostograms. You need cross-sectional imaging, and oftentimes you might just see strictures and you might never actually find out exactly what they're from. In the leak situation, the tough technical situation, because you don't have dilatation of the collecting system, and it might be difficult to place a nephrostomy. Again, contraindications, not a whole lot, mainly anatomic. So for instance, if there are cysts or intervening structures, colon can come into play when you're planning a nephrostomy tube, because it can be intercalated between the abdominal wall and the kidney, and so that's one structure to watch out for. Bleeding diathesis certainly have to be corrected as well. You can use landmarks, but we pretty much now just use ultrasound. If you were asked about how to plan for nephrostomy by landmarks, you're going to puncture subcostal to the 12th rib, 4 finger grafts from midline. That's going to be a reasonable place to start puncturing. But with ultrasound, it kind of takes that element of surprise away a little bit. What you want to do is puncture the peripheral calyx as much as possible. You want to stay away from the central structures, because obviously that's where the vessels are in the hilum of the kidney. And so by puncturing in the peripheral calyx area, you're hopefully going to eliminate the possibility of the bleeding complication. And so here again is a slide, so demonstrating central vessels. That's the area that you want to avoid when puncturing the kidney, and this is a good puncture. And this is not so good, right? So here you see the tube is basically going right into the renal pelvis, not an ideal puncture. So again, going back to the complications, major complication of nephrostomies is bleeding, and here you see the nephrostomy tube has been placed, and there are these very sort of bulky filling defects within the collecting system, and those are blood clots. Those can form very, very quickly, and there could be quite a bit of bleeding during the nephrostomy placement. Also, particularly for patients who are presenting with infection, you have to worry about sepsis, and those patients I actually advocate injecting no contrast at all during placement of the tube, and just doing everything under ultrasound and fluoro, or injecting the minimum amount of contrast, not to over-distend that kidney and not to put the patient in the septic physiology. Here's one way of dealing with the bleeding complications. So this patient actually had an arteriovenous fistula and hematuria related to injury to the renal artery, and had to be treated with coil embolization of the injured branch of the renal artery. For ureteral stents, now here is again simple plumbing. Again, it's for obstruction or leaks. And what you're trying to do is place the stent beyond and through the area of the obstruction and allow a conduit for the urine to go down the ureter into the bladder. So here's one example where there's a malignant obstruction going on and a stent is in place, allowing the urine to go down into the bladder. Here's another nice example in a transplant setting. As you can see, there's pretty massive dilatation of the renal pelvis, and here's the stent going down into the bladder, a short transplant stent. Here's another nice example, a very long ureter, also in the transplant setting, and this patient also has a urine leak or urinoma, and so this patient actually was treated with a nephroureteral tube. Now, this is not quite a stent, but a nephroureteral tube, and another example of a nice clot. So, you know, if you see, this is the puncture of the kidney, and then this is just a couple minutes later, a huge filling defect. That's a nice example of a blood clot appearance within the collecting system. And then there's the tube going all the way down to the bladder. All right, and then in the last few minutes of the talk, we'll cover percutaneous abscess drainage procedures and some special situations that pertain to drainages. So as far as technique is concerned, simple salvage technique. Some kind of cross-sectional imaging for guidance helps very much. Ultrasound, if at all possible, because that really can shave a lot of time away from the procedure, and doesn't require a potentially precious CT source, but resource. But if you have to use CT, use CT. A lot of the time, it might be difficult to know where the bowel is, for instance, compared in relation to the fluid, and so CT can come very helpful. You're going to take the shortest route. You're not going to want to go through bowel, but through liver, stomach, rectum, vagina, transpleural. Those are all reasonable ways to proceed if there is no direct percutaneous approach. Sometimes the collection is really deep and surrounded by bowel and bone and various other structures that you don't even know what they are sometimes, and in that case, you can't do it. If you can't do it safely, by a percutaneous approach, especially down deep in the pelvis, think about alternative approaches such as through the bowel or through the vagina, and we'll cover some pelvic collections in just a little bit. But sometimes, like in this particular case a couple of years ago, we had to tell the referring service that we just can't do it, in which case you might just treat conservatively with antibiotics and rescan, because a lot of the time, if it's going to get worse, it might become larger, and there might be a window at that point. Alternatively, there's always surgery, the good old way of treating abscesses before IR was around. So this is a nice example that we ended up treating by a transgluteal approach. This was a periappendiceal deep pelvic abscess. And so here you are. One thing to remember about transgluteal approach for abscess drainages is that you want to stay as low as possible and as close to the sacrum as possible. And that way you're going to avoid the vessels and you're going to avoid the sciatic nerve. And so that's what we're doing. We're kind of hugging the sacrum. You can go even closer to the sacrum without lifting the periosteum, because that would be really, really painful for the patient. And then go ahead and access the collection. Place the wire, dilate the tract, put in the tube. 12 French tube is a reasonable way reasonable size to think about for percutaneous abscess drainage. In this particular case, there's not really a good way to get to this collection in the gallbladder fossa after cholecystectomy, and so you can go through the liver if you have to. Probably worth advising the patient that there is probably higher than average risk of bleeding in this particular situation, but completely doable and safe. So here it is, drained. On occasion, special situations are going to arise, like the splenic abscess, pancreatic fluid collections, liver abscesses, and tubo-ovarian abscesses, and we'll cover those briefly as well because they, on occasion, come up. So, abscesses in the spleen, you can drain, but oftentimes you don't have to, because a lot of the times they're going to respond to antibiotics alone. And so you might just be able to write it out. So, de novo presentation of a splenic abscess, say, let's just give them some IV antibiotics, rescan in a couple days, and see how it is. A lot of the time it'll be smaller, and if it's not smaller or larger, patient is not doing well clinically, then it can be safely percutaneously drained. Again, spleen is very vascular, so we're concerned about bleeding here. Pancreatitis collections, tough problem. So in an acute situation, it might look like fluid, but it might actually be quite gelatinous in consistency and might actually not be drainable. You have to ask yourself first, what's the indication for drainage? Is it just because the collection is there? Just because the collection is there and the patient has pain does not mean that you have to be putting in needles in it, because the worst thing you can do is infect a sterile collection around the pancreas. And then infected pancreatic necrosis actually carries a substantial mortality with it. So that's one thing that we can try to prevent by not draining too soon. But when you're worried about something, when you're trying to just sample and you're worried about infection, you're just trying to sample it. Sampling it is fine, biopsying the fluid, and if you have high suspicion for infection, and then you need to put in the drain, then you need to put in the drain. So what you might be dealing with pancreatitis is acute fluid collections, which, as I said, might actually not be collections. They might not be fluid, might be gelatinous material. Pancreatic pseudocysts and pancreatic abscesses. Patients must be symptomatic, as I said, most commonly infection is what you're worried about. A lot of the time, it's really hard to get to those collections. They're deep in the retroperitoneum. There's going to be bowel and spine and vessels all around these collections, and a lot of the time, your window is going to be yay big. But nevertheless, that's a window. So this patient had suspected peripancreatic abscess, and so we were able to actually sneak in a skinny needle. If the collection is so small and you're worried about bleeding in the kidney and injury to the colon, it might be reasonable to even start with a 21 gauge needle or 22 gauge needle, and then upsize using one of the conversion sets to an 035 wire system, and then dilate up and put in a tube. So this is one of those examples. In the pseudocyst situation, try to avoid draining them percutaneously, because once you drain them percutaneously, that creates a very happy track from the pseudocyst to the atmosphere, and then it might be very difficult to actually find a situation that's where you can actually remove the tube. A lot of the time, these patients might be able to get a cisgastrostomy, either surgical or endoscopic. So for instance, if you have an endoscopist who has EUS capabilities, they might be able to see the cyst through the wall of the stomach, puncture sharply into the cyst, and then place their double J stents across from the stomach into the cyst and relieve the pressure on the cyst that way. And that really avoids that potential issue of pancreatico-atmospheric fistula. In the cases of peripancreatic infections, a lot of the time, yes, you can drain them. We certainly drain them at UCSF all the time. You might need to put in a large bore drain, and you might need to be prepared to change these drains all the time, because this is very thick, tenacious material. The drains are going to be clogging up a lot, and these patients are going to be back weekly and sometimes even more often to have these drains adjusted and replaced. But it can be done without an operative approach in the cases of infected pancreatic necrosis. All right, what about liver abscesses? Now, the tough thing about liver abscesses is that they're not always drainable, because it might look like an abscess, like it does here, but as you can see, there's a lot of tissue that's within this cavity that actually is semi-solid or solid, and it's not going to be coming out through the tube. And so dead liver doesn't really come out through the tubes, and so the liver abscesses in an acute setting are actually not particularly drainable. But if you sit on it for a little bit, so this is just a week later, it coalesces together and becomes drainable, and actually responds very well to percutaneous drainage. Beware of infected liver metastases, because sometimes it looks like it's going to be a liver abscess, but in reality, if you look back on scans, there was actually a liver mass there, and an infected metastasis oftentimes is not going to heal with tube drainage, and so be prepared if you're going to be putting in that tube, that the tube might be for patient's lifetime. TOAs respond really nicely to antibiotics. And so just like splenic abscesses, new diagnosis of TOA does not require drainage a priori. You can wait on it for 48, 72 hours, rescan, and then if it's getting worse, it's not going away, then you can consider drainage. As far as approaches, percutaneous approach is reasonable if it's superficial enough, like in this case. But sometimes it's too deep. Here you are, there's a tube check, actually gives you a kind of a freebie hysterosalpingogram. There's the fallopian tube. If it's too deep, then consider transvaginal approach. And so here's one setup with a needle guide and a vaginal probe. And here's a fluoroscopic image where the tube is in this abscess cavity, and then you can see abscissification of the vaginal wall. So on occasion, you can use a transvaginal approach for TOAs, and that might be reasonable. All right. This looks like a slam dunk abscess, no problem. Easy approach. Nothing in between, going transverse. So this is an abscess that contains air and fluid, diverticular. One thing you might be worried about is that there's going to be communication with the colon, especially with this appearance, and that's indeed what you see. 3 days out, you just see a huge cavity, no communication. It doesn't mean that the communication is not there, you're just not injecting hard enough to actually pacify it. But then 10 days later, the cavity has collapsed, and when you're injecting it, you're seeing wide communication with the colon. So this is clearly a bowel fistula, and there is actually still a question whether or not this fistula is going to heal with tube drainage alone. When you're faced with an enteric fistula, you're going to manage it with tube drainage for a while, oftentimes at least 6 weeks, and enteric diversion as well as perhaps TPN. What determines success is where the fistula is. So small bowel fistulas actually respond better to tube drainage than large bowel fistulas, and also output makes a difference. So if their output is less than 200 cc's a day, that's actually a good prognostic factor for fistula healing, as well as etiologies of fistulas. So if there is no intrinsic bowel disease, those fistulas are more likely to heal than if there is radiation or inflammatory bowel disease that's involved. As far as the results of percutaneous sepsis drainage, overall excellent. It's a good and effective method of treating intra-abdominal infections. Failures are fairly uncommon, and the side effects are pretty rare. Bacteremia requiring interventions 2 to 5%. That's really the highest risk. On occasion, patients might become septic, so it's actually very, very important to make sure that your patients are receiving antibiotics prior to you getting involved with the drainage. So that is going to be pretty much what we've covered.